All right, so we made 3 updates to our protocols that we'll be educating you guys on today. So we'll be going through all 3 of those protocols and kind of the whys of why we updated them, and hopefully answer some questions that you may have. The go live date will be August 14th at 0600. We'll be working on distributing the updated protocols to the rigs and also to the employee website, and getting you guys some reference material as well, some LA Motor Score cards to help the transition a little bit. So the first update is to our stroke protocol. The first thing we updated is we went from utilizing the Cincinnati Pre-Hospital Stroke Scale, which is a stroke screening tool, to the LA Motor Score, which is where the LAM scale is a stroke severity tool. So this is an American Heart Association recommendation, and we'll be going to the LA Motor Score as opposed to the Cincinnati Pre-Hospital Stroke Scale. So I'll be working on some reference cards that you guys can put on your badges so that you can reference that as needed. And really the goal of this whole protocol update is to target treatments for patients. And we'll be extending the window for activation to 24 hours as opposed to 8 hours. So there are going to be certain types of patients that we're going to be activating in a 24-hour window as opposed to an 8-hour window, which is our old protocol was. So patients that have a LA Motor Score of greater than or equal to 4 and symptoms are within 24 hours of onset, so last known well time is within 24 hours, we're going to activate a field cold stroke on. And we'll get to why we'll be activating those types of patients in a little bit here. And then patients who have a LA Motor Score of less than 4, so 3, 2, or 1, and symptom onset is within 8 hours, we'll still activate that field cold stroke. So 2 different windows. Basically, we're looking at the 8-hour window and the 24-hour window. So in the protocol and how it looks, so under the advanced EMT, intermediate, and paramedic portion, we'll be notifying the receiving hospital and activate a field cold stroke if the patient has a LAM score greater than or equal to 4 and symptoms that are within 24 hours, or the patient has a LA Motor Score of less than 4, so 3, 2, or 1, and symptom onset is within 8 hours. All other care remains the same, same kind of benchmark, same everything that we will be doing in the past, and then we'll still be transporting to the nearest CT capable facility. So why the 24-hour window for LA Motor Score greater than or equal to 4? And really that's for one reason, that's for treatment of what's called a large vessel occlusion. So a large vessel occlusion is acute ischemic stroke due to large vessel occlusion, vertebral, basilar, carotid, terminus, middle, and anterior cerebral arteries, likely portends a worse prognosis than stroke unassociated with LVO. So basically it's a stroke that is going to benefit from having endovascular care performed on it, so coiling, going in and removing the clot, as opposed to a smaller vessel occlusion that TPA is the best treatment for that. So the American Heart Association found that large vessel occlusions do have positive outcomes if they are treated endovascularly within a 24-hour window. So the studies found that the LA Motor Score was a good indicator of finding a large vessel occlusion. So patients that had greater than or equal to 4 on the LAM score had about an 80% chance, give or take, of having what's called that LVO, or that large vessel occlusion. So we know that the best treatment for those types of patients is endovascular care, or that coiling and removing of the clot. And so that's why we went with the 24-hour window for the greater than or equal to 4 on the LA Motor Score. And then again, the same window, 8 hours or less, for stroke patients that have a LA Motor Score of 3, 2, or 1. So really we're looking at between 8 and 24 hours for LA Motor Score greater than or equal to 4, and 8 or less for any other score that we find there. So that's just showing, this picture here is showing that 80% sensitivity and specificity of the LA Motor Score. So what is the LA Motor Score? So it's a 0 through 5 scale that we'll be using. So in the past it was just the Cincinnati Pre-Hospital Stroke Scale was arm drift, facial droop, and slurred speech. Are you having one of those? Yes, we're going to activate the field cold stroke. where now we'll actually be looking at the individual, giving it a severity, so 0 through 5, and then kind of that'll dictate on whether or not we'll be activating the field code stroke. So taking into account the number from the LA motor score, and also the window, so how long had the stroke symptoms been going on for, and that will determine whether or not we'll be activating that field code stroke. So LA motor score looks at face, arm, and grip. So again, 3 components: facial droop, arm drift, and grip strength. So the first one is pretty simple. Facial droop, is it absent or is it present? So if they have no facial droop, they get a 0. And if they do have facial droop, they get a 1. Arm drift, so no arm drift, again 0. If the arm drifts down just slightly, we're going to give them a 1. If it falls rapidly, they have no control, nothing, it's completely flaccid, then we're going to give them a 2. So again, 0 being very, very, nothing is going on, 1 being very, very minor, and 2 being falls rapidly. So obviously the higher the number we're giving them, the worse the stroke symptoms are. And then grip strength. So normal grip strength, they're able to control their hand completely, have good grip, equal bilateral grips. We're going to give them 0. Weak grip, so it's a little bit weaker than the other side, we're going to give them 1. And if it's no grip, they can't even move their hand, it's going to be a 2. So 0 through 5, if they have a 4 or greater, we're going to be activating a field code stroke if it's within that 24-hour window. And if it's a 3, 2, or a 1, then we're going to activate within the 8-hour window. So how do we document that? It's going to be documented in the vitals portion just as you were, but instead of using the Cincinnati scale, you're just going to mark it as the Los Angeles scale. And then you're going to document all 3 areas and the score in your narrative. So you're going to document that the patient had facial droop, so that was 1. They had arm drift, that was just slight, not completely flaccid, which is another 1. And then they had 0 grip strength, so we'll give them a 2 there. And that's what you're going to document in your narrative, so that's going to be a 4. And so we know 4 and greater is going to be activation of a field code stroke if the symptoms are within 24 hours. So 24 hours and a greater than or equal to 4, we activate field code stroke. If they're outside of that 24-hour windows, we're not going to activate. Or if they had a 3, say they had a 3 instead of a 4, and they were between 8 and 24 hours for onset time, then we're not going to activate. But under 8, we would activate. Again, you're going to activate and document stroke activation, and this is for all patients with a score of 1 or greater. And then document destination of the patient. So did you go right to CT? Did you go to the ER? Was the patient prepped for CT? All that good stuff get documented in your narrative. Nothing really changed there. So Pulsera, so the change in Pulsera is that we're no longer going to be documenting our vitals score as the Cincinnati. We're going to the LA motor score. Pulsera receiving hospitals in this area are St. Elizabeth's, Mercy Medical Center, ThedaCare Appleton, and ThedaCare Neenah. So when you get into Pulsera and you get into the stroke section, you go into stroke vitals and our last known well. That's important to have an accurate description there. And then you go into your stroke scores. Click on that add score or that plus score, and it will bring you right into the stroke score itself. So you're going to be changing it from the Cincinnati scale to the LA motor score, or LAMS, and then that's going to give you exactly what you need to give it the score. So once you know that it's greater than 4 and you're within a 24-hour window, activate. If it's less than 4, you're in within an 8-hour window, then activate. So the other updates that we did were to our trauma protocols. And really we did that for a couple reasons. One was to be more in line with the geriatric care in this area and the recommendation from the American College of Surgeons, and also to be more in line with our local trauma center and kind of the updates they made recently, and not only in regards to geriatric care, but some of the other trauma alert protocols. So under the C-spine protocol, we added so we have the Nexus criteria, which is our typical 5 exclusion criteria, and then we added in there an age qualifier as well. So in the past we only had 5 things. We added a 6th for clearing C-spine. And then the trauma alert protocol addition, so under the respiratory rate, so we added the need for ventilator support and intubation was added. Under pulse rate, so anything that's less than 50 or greater than 130, we can consider activating a trauma alert. greater than 20% total body surface area burns added as a consideration. And then we changed patients that are greater than 75 years of age and had a fall that was greater than 10 feet. We should be activating a trauma alert, where in the past it was always 20 feet and greater. Now with the geriatric population, it's going to be greater than 10 feet only. So for the Siepstein protocol, again, same 5 criteria that we've always had: absence of posterior neck tenderness, absence of focal neurologic findings, normal level of alertness or a GCS of 15, no evidence of intoxication, drugs, or alcohol, absence of any painful or distracting injuries, and then patients, they have to be less than 75 years of age. If a patient is greater than 75 years of age and has a traumatic injury that could have resulted in a C-spine injury, we're going to protect that C-spine every time, even if they are clear on the other 5 categories. We've actually had patients that we were able to clear C-spine on. We got them into the hospital, they got scanned, and they found a cervical spine injury. And that was really because of the age and their inability really to sense pain, and kind of their brittle bones and some of the other physiological changes that result from aging. So any patients that are greater than 75 years of age and have a significant traumatic injury that could have resulted in a C-spine injury, we're going to protect that C-spine every single time. So really the reasons for that, geriatric trauma right now is really being looked at really closely, and really because minor mechanism of injury can produce really potentially lethal injuries. So these minor falls and it can result in major injuries. So these patients respond differently to bleeding, shock, and trauma. They have decreased hearing, reflexes, poor vision, and underlying medical conditions, so they fall differently. They're not bracing themselves. They aren't able to respond as well and position their body in a way that can protect them from injury. And age also affects pain perception. So we've all had that geriatric patient that has a really obvious injury, but they're really just not complaining of any pain. So those are the ones that you can't really define that as a distracting injury because they're not distracted from it. So we really need to be extra careful of these patients, because they may have a cervical spine injury but may not be responding to that pain. And they have C1 or odontoid fractures with the minor mechanisms such as a fall are much more common in these patients. So 75 years and greater, we're going to be protecting the C-spine every single time if they have a mechanism that could have resulted in a C-spine injury. And just to reiterate, so we updated the field trauma alert criteria. The need for ventilatory support and intubation, that was added in there. I know it was kind of inferred in the past, but now it's spelled out there. Pulse rate less than 50 or greater than 130 with associated trauma is a qualifying injury. And then greater than 20% total body surface area burns. And then the 75 years and greater of a fall that is greater than 10 feet will be activating on.